Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Alexander Saw. Dr. Saw is a native of Fremont and was born at Washington Hospital. Dr. Saw completed his bachelor's degree at Haverford College in Pennsylvania. He completed his internship at Massachusetts General Hospital and his residency at Harvard Combined Orthopedic Residency in Boston. Dr. Saw completed his fellowship in minimally invasive and revision hip and knee replacement at Rush University Medical Center in Chicago.
Well, thank you so much for coming today on this Friday afternoon. It's my great pleasure to be here to talk to you about hip pain, hip arthritis, the treatment of hip pain, and things like hip replacement. So I like to try to keep this as interactive as possible. So at various portions of this talk, I'll open up to questions, and you can either ask them at that time or we can answer questions at the end. But again, thank you for being here. It's a great privilege to come here and give this talk. As Lucy said, I was born in this hospital, at Washington Hospital. My father was a head and neck surgeon here, so it's great to come back to this community and provide these education seminars to the community where I was born. I did do my schooling and training out east, and I've been here since 2008. This is actually a picture of me with my father. Again, a retired ear, nose, and throat surgeon from many years ago. He practiced here for over 30 years. And again, it's a great privilege to practice at the same hospital in the same community and be recognized by the various community members and these awards for orthopedic care here. With the orthopedics that we do here, I've been able to participate not only on the local level with Washington Hospital, a co-director of our Institute for Joint Restoration, but it's also allowed me opportunities to chair national committees and meetings, and I'll talk about it a little later about the research we do here. On the sheet that was passed around, you can see that things that I specialize in are total knee replacement, partial knee replacement, revision knee surgery, also hip replacement and revision hip surgery, and today again our focus is on hip arthritis and hip replacement. So this is an overview of what we'll talk about today. We're going to try to be ambitious and talk about a number of topics, and again I'll answer questions as they come about. First, we'll talk about just hip basics, so just anatomy and function, so everyone can get a brief background of what we're talking about. The hip joint, some people don't know exactly where it lives. It lives really in the crease of the groin. So some people refer to back pain or buttock pain as being their hip. The hip joint, when it's causing pain, typically presents more in the groin area, but it can refer to the side of the hip. But just so people are aware, there are other things in that area that can refer pain there, often the lower back, kidney problems, or other things. Those things can all refer pain in that general area. But today we're talking mainly about problems that affect the hip joint, which you see here is this ball and socket joint. So if you look at that closer, this is an anatomical drawing in one of our anatomy books for medical school that look at the hip joint, which is again a ball on the top of the thigh bone or femur, and that ball articulates in this socket called the acetabulum of the pelvis. So on here you just see half of the pelvis, but this is a representation of that ball and socket joint with the blue representing the cartilage. Here's another schematic, again, the white being cartilage, ball and socket joint. And as we all know, the hip joint gives us many degrees of motion. So it's almost like the shoulder in that it can do things like what we call flexion, extension, abduction, and adduction, and it can do rotation. So all of these things, all these motions are made possible because it is a ball and socket joint. But because it's a ball and socket joint, there are obviously many areas where a wear can occur, arthritis can occur, or problems, which can thus limit motion and cause hip pain. So what is arthritis? When we talk about arthritis, typically what we are referring to is breakdown of that cartilage, breakdown of that protective layer in the joint. Arthritis, whether it occurs in your hands, knee, shoulder, or hip, it's very common. It affects young people, it affects old people, it affects millions of Americans every year. One analogy that you can use with arthritis is that the joint is somewhat similar to the tire on a car. So why do some car tires wear faster than others? Well, it may be bad quality rubber. It may be that it started off with a defect, and so over time it wore more quickly. It could be the driving habits of that person or that car, so that obviously someone who goes faster, goes harder, it may impact the wear and tear of that tire, similar to a freeway. The high frequency, high weight right lane often breaks down more than the less often used left lane. But all of these things, what happens is, like a car tire, like a joint, that cartilage gets worn. So rather than being smooth, it becomes pitted, it becomes eroded, and then the underlying bone is exposed, and that's what causes the pain, stiffness, and discomfort. The typical symptoms of hip arthritis, at least, is anterior groin pains. Like we said, it often presents in the groin or the medial thigh. Sometimes it's on the outside of the thigh. It typically occurs with weight bearing or with doing stairs or other things. Some people will feel catching or locking. That's not as common, but it's generally discomfort and stiffness in that groin area. Somewhat analogous, I tell my patients, to a square peg in a round hole. That joint just doesn't move as well as it typically should. It's important to know that while some people will have hip arthritis or hip pathology causing pain, this is an x-ray of an arthritic hip, and we'll go over more of this later, that a third of patients will actually feel the pain in their knee. So the problem can be coming from the hip, but that patient may experience the discomfort in the knee. So as a clinician, as a physician, it's our job to figure out the source of the pain, but just so you know, a third of patients who have a hip problem may feel it as a knee problem. Here's an x-ray of a typical hip, and here's the ball and socket on x-ray, and this space right here between the two bones is where the normal healthy cartilage is living. Cartilage is invisible on x-ray, so what keeps the bones apart is that white protective layer, that white cushion on the end of a chicken bone, for example. Every joint in your body has it. That cartilage allows the joints to move freely and without pain, and on x-ray, that's represented by that space. When you start to have arthritis or breakdown of that cartilage, you can see that space gets smaller. There's still a little bit there, but it's much more narrow. But as arthritis progresses, well, now you can't really see it, and now the bone is getting harder and getting white. It's getting hard like marble because there's no cartilage there, the bone's rubbing on bone. And so this is a classic picture of hip arthritis on x-ray. It can become more severe, where now actually cysts form. You can see how this hip joint is actually moving out of the socket, the ball's moving out of the socket. Those cysts are another sign of hip arthritis. And it can become so involved that you can see this person has actually eroded through their head. It doesn't even exist anymore. So these are all various degrees of hip arthritis on x-ray. The bottom line is that there's no cure for arthritis. Once that cartilage is lost, unfortunately we don't have the technology or the ability to put cartilage back in the human body and have it grow and withstand the forces it's subjected to every day. So similar to a car tire, once it's blown out, it needs to be replaced. This is an example of some normal cartilage on a hip bone, a femur, and here's the absence of cartilage. All right, so just as a basic background of the anatomy and what arthritis is. Next we'll talk about non-operative treatments. So how do you treat hip pain in general? Whether it's arthritis or a sprain or a strain, what do you do to treat it? This is one of the most common things to use. So an over-the-counter medication, an NSAID or non-steroidal anti-inflammatory drug. These are your ibuprofens, Advil, Motrins, things of that nature. These are very useful to help mild discomfort. They reduce pain, they reduce inflammation. The things to know about it is that they are metabolized by the kidney, so people who have kidney issues may need to have caution with it because it could further stress the kidney. Also, people taking blood thinners have to have caution because this has a reversible effect on platelets, so it can thin the blood a little bit more. So people who are on Coumadin or Plavix may want to be cautious taking this because this may additively thin their blood more. This medication also can cause GI upset. It can cause stomach ulcers theoretically. That's why we recommend typically taking it with food. But there are side effects of taking any medication, but the most common with an anti-inflammatory like this, an NSAID, is bleeding if you're on a prior blood thinner, GI or stomach upset, it's really actually those two are the two most common downsides of taking this. But it works very well. It's safe. I give it to my children. Many people use it, but you want to try to use as little as necessary, of course. But it works very well as first-line treatment for any joint discomfort. Aspirin's another anti-inflammatory. Many people are probably on it for heart reasons, protective reasons, but aspirin is an anti-inflammatory. It's a little bit different in that it irreversibly affects platelets, and so it thins blood possibly even a little more. So you have to be careful, again, if you're taking that in addition to another blood thinner. Tylenol or acetaminophen, it's a nice mild pain reliever, but just so you know, it's not an anti-inflammatory. It does not reduce inflammation. It helps with pain. And it also, unlike the NSAIDs, does not affect blood thinning properties. So if you're on Coumadin or Plavix, you can take acetaminophen or Tylenol quite safely. It will not affect that, but it also is not an anti-inflammatory. It also does not affect the kidneys. So if someone's trying to avoid the NSAIDs because of kidney issues, they can take Tylenol safely. It's metabolized by the liver, but it's not an anti-inflammatory. After those over-the-counter medications, if the pain's significant enough, people will often go to pain medications or analgesics. People have all heard of Tylenol with codeine, Vicodins, Percocets, things like that. But typically, if you need a medication like that to control joint pain, you typically need to see a physician or be evaluated. How about supplements? Anyone in here taking glucosamine or other supplements for their joints? Sure, it's very, very popular. It's over-the-counter. It's a natural supplement. It's a compound found in healthy cartilage. Just so you know, it's not approved by the FDA, and so it's basically classed as a dietary supplement, meaning there's no data to show that it actually does anything specifically. There's no data to show it's better than placebo, but people take it and it may work for them. I don't have any problem with that. But just so you know, because it's not regulated by the FDA, brand 1 may be very different than brand 2, and there's no real regulation of what is in what. One of my mentors gave me a great analogy, which I'll never forget. Because glucosamine chondroitin sulfate is a building block of cartilage, he made the analogy that taking this is analogous to a bald man who eats hair. Just because you eat it doesn't mean your body is going to put it exactly where you want it. So something I remember, but again, I won't argue with anyone who takes it and finds that it's beneficial. At most, it's an out-of-pocket expense, but just so you know, there's no data saying it necessarily does anything. Other things that you can do with hip pain is modify your activities. You can use a cane, you can avoid walking the golf course, you take the cart instead, you avoid the stairs, you take the escalator, and then also weight. Weight is a major factor. The hip joint feels up to 3 to 5 times body weight, meaning if losing 10 pounds is 30 to 50 pounds potentially of force taken off that painful joint. So it's something to be aware of. Okay? So what is hip replacement? Well, hip replacement is really a resurfacing of the hip. It's making a new hip joint. The problem, again, we talked about is where that ball and socket is no longer functioning well and is too painful and stiff to provide activities of daily living comfortably. So Sir John Charnley in the 60s actually developed hip replacement, and Dr. Bill Harris at Harvard in the 70s really became the American godfather of hip replacement, and I had the opportunity of training with him when I was there, and I saw him last October actually. But he's really pioneered a lot of hip replacement in America. And so if you look here, these are various implants that can be used. It can be cemented into place, and it can be placed without cement. There are various techniques and components. Let me just show you this here. This is an actual prosthesis. So just like the picture that I just showed, this is the implant that goes, let me go back, that goes into the thigh bone. So it goes into the femur. And what happens is the bone actually will grow into this, and then we put a metal ball, making the new ball socket of the hip joint. This cup goes into the pelvis, the bone grows into it, and then what happens is as the leg moves, the hip moves. So in this case, it's metal on plastic. So I will pass this around so you can feel the weight and see what a hip replacement feels like. Thank you. And from the other side, I'll pass around this model, which shows essentially that implant placed in the bone. So you can see that stem goes in the middle of the thigh bone. The bone grows into it. There's a ball in a socket, and that socket basically goes into the pelvis where that hip joint is. So you can see that hip now moves like so. So I'll pass this around. And so obviously to do that, we have to do a surgical approach. This is just a diagram and a picture showing what it can look like to expose the hip and replace the hip. Traditional hip surgery, this is one of our medical drawings of how to describe hip replacement, that we learned in medical school. It shows the approach, shows traditionally how to replace hips, but you can see we've advanced it to the point where it's a much smaller incision. so it's a faster recovery. So things have really advanced from traditional hip surgery. The reason we do less invasive hip surgery here is because there's potentially a shorter recovery time. There's less patient pain, less blood loss, a shortened hospital stay, no increase in major complication rate. People return to function and walking much earlier. So based on our experience, where we do roughly 14 to 1,500 joint replacements here a year, based on our research, the published literature, this is typically what we will do in most patients. So we will do a less invasive surgical approach on essentially all comers. Typically it's a mini posterior approach, meaning it addresses the hip it's on the side of the hip, but to the back portion of the thigh bone. We're typically uncemented, like what you're passing around now. We will use cement in osteoporotic bone in our very elderly when necessary to reduce risk of fracture, but still give good outcomes. And we typically use a metal head on a plastic bearing. I'll talk a little bit later about the various bearing options. And usually we use an epidural anesthesia where people are numb waist down so that they can avoid general anesthesia and other complications associated with that. This mini posterior approach we do, the advantages are that it's a very commonly done procedure. It is easily made more extensile if necessary. It avoids trauma to some of the major muscle groups to avoid limp, and it's amenable to both cemented or cementless techniques. With the mini posterior approach, the way we've done it, obviously with a small incision, there's much less injury to soft tissue, less injury to muscle, so that people can walk hours after surgery, go home the next day, and recover very quickly. You can see these are various instruments that we use to do the hip replacement. This is a reamer that we use to prepare the cup. This is the actual cup that you're passing around going in, but you can see it barely squeezes through that incision. And here is us approaching the femur, getting it prepared for the stem. Again, small incision, but it allows us to do the surgery safely with a fast recovery. This is actually a video of the surgery. So if you don't want to watch, you obviously don't have to watch, but if you just want to have a rough idea, this is what we do. So the person's lying on their side, this is their left hip. The skin looks yellowish because there's a protective antibiotic drape on it. Those purple lines are what I use so that I can, when I suture the skin together, line it up. This is an electrocautery, which basically cauterizes blood vessels as it dissects through soft tissue. And then here is a saw, which we use to remove that femoral head. So we do have to use some major power tools to do this procedure, but this is what we do to prepare to make space for the implant as you're passing around. So the person's asleep with an epidural anesthesia. Some of our patients are awake, waist up, so they're actually watching the surgery, talking to us during it, believe it or not. Some want to be drowsy and asleep, and that's okay. Here's the femoral head being removed, and so what you can see is that there are large areas of cartilage missing. And so that's why this person's walking with pain, and so we remove it so that we can replace it. That's that same reamer I showed you before. It's hemispherical. Basically it spins and it prepares the cup portion so that we can fit that metal cup that you've passed around. Everything blue is sterile. Again, we do everything sterilely in our operating room. Yes?
How long is the operation?
The surgery itself actually takes only about an hour, 15 minutes. It's much faster. When I was in training, it could take 2 to 3 hours. People were in the hospital 4 or 5 days. They were on crutches for 6 weeks. Things have changed a lot during that time. So here's preparation of the stem. The cup had just gone in. And so using a hammer, we can broach or basically fit the correct size into the thigh bone. Again, a lot of this is like carpentry of the bones, if you will. Because we have to make enough space where we can fit the largest component that fits snugly without being too big and fracturing the bone. So it's a balance. But we're working through this small incision, preparing this side for the eventual stem which you've passed around. Once that stem is in, that yellow ball is essentially a trial ball. It gives us an idea to put the hip back together and test it, make sure that we like the stability, the leg length, and everything else. And once we're happy with it, there's that real stem, which is identical to what you've just passed around.
What kind of metal is that made of?
That's titanium. And so that porous surface, that roughened surface that you feel, that is where the bone will ingrow. So by impacting it so that it's snug, that's what allows the bone to grow into it. If it's too tight, bone can fracture. If it's too loose, it may not grow in. then these components are modular, meaning that the stem is different than the head and that the cup has a liner. These things can be altered to fit just right for the patient. So we put the hip back together and make sure that we're happy with how it moves and the leg lengths and everything else. Okay, so this is an example of a patient a number of years ago who we just picked randomly just to show what can happen with hip replacement. So this gentleman, these were his x-rays prior to surgery, and you can see that he doesn't have much cartilage left. He was very limited. He was a normally very active gentleman who was requiring a cane and could hardly walk. You can see how he's limping pretty badly, and it was probably even worse if we weren't taping him. But he could not do things without a cane or a walker, and that was not what he used to do. Here's his surgery. You saw we just put in the stem. We put in a new hip socket. We get him up walking just 3 hours after surgery. That's our therapist behind him, using a walker at first. And I don't have the audio, but what he's saying is his knee pain, remember hip pain can refer to the knee? It's gone, is what he's saying, even 3 hours after surgery. This is him walking the morning after surgery. And before we let people go home, we make sure they can do stairs and walk independently and do everything that they need to do. So this is the morning, less than 24 hours after surgery. What he's saying is he's feeling well, ready to go home. This is him 12 days after surgery in the clinic. You can see he's walking much better, and you'd be hard pressed to know which side was the replaced side. So hip replacement recovery has come along very quickly, recovery much faster, and this is just one of our typical patients. So in terms of our rehab, weight bearing, weight bearers tolerate it. So like I said, in training, people were walking on crutches for 6 weeks. We have people walking immediately, full weight bearing. Walker day of surgery, off into a cane, maybe even going home with a cane the next day. And we will focus on stretching and simply walking. That's the therapy. Our last 2,500 patients, average is the next day, they go home. Typically 90% are discharged using a cane or nothing else, and over 95% go home. Not to a rehab, not to skilled nursing. Patients are able to be discharged home safely. Risks are rare, something like hip dislocation, fracture, blood clot, all these things far well below 1%. How do people do? We expect people to walk on a cane quickly, rid of the cane hopefully by 2 weeks, driving after a couple weeks, golf at 6 weeks. We want people to feel pretty much recovered and like a normal hip at 3 months. We want people to say it feels like a normal hip. This picture I love to show because this is a 89-year-old patient of mine who had a hip replacement by me, and every year he goes to Mexico with his other 90-year-old friends, and they play poker and they go boogie boarding. He fractured this, he had his hip fracture and hip replacement 3 months prior to this, and he sent me this picture. This was him going on his trip at 89, 3 months after his hip replacement. So people can recover very quickly. Now, there's hip replacement, and then there's less invasive hip replacement, minimally invasive hip replacement. And I'm going to try to introduce some concepts and try to answer any questions because it can be confusing understanding what's in the literature or what's out just in the public display of TV ads and magazines. But if you Google minimally invasive hip replacement, this was a couple years ago, in 0.1 seconds, there's 114,000 links. So there's a ton of information out there, and it's hard to figure what is true and what is not. Less invasive surgery simply means hip surgery, but through a smaller incision. Traditional hip surgery, as you saw in those prior diagrams, was through a big, long incision. Now they're much smaller to help with recovery. There are various ways to do a hip replacement. It's called anterior, lateral, posterior. They're all various approaches. The bottom line is what you need to know is with all these approaches, the ultimate outcome is typically the same. I just came from a national meeting in Dallas, and those studies have shown that regardless of approach, at 6 weeks, people are typically doing exactly the same. But there are different pros and cons of each approach, and people will market it and advertise different things, so you need to have an understanding of what it is. Not everyone does less invasive surgery, first of all. Why? Because it's difficult. Doing this surgery through a small incision can be hard for some surgeons. They may not do it technically well. And what you don't want to do is compromise the underlying surgery, right? We want this to be a long-lasting, good result. We don't want to force something through a small hole and compromise those long-term results. But in high-volume surgeons who are skilled, they can still give that long-term result through a smaller incision. The modified Harding is essentially a lateral type approach, and it would go through the muscle. So an abductor muscle on the side, that's how you approach the hip. Classically, in the older literature, the benefit of it was that there was a lower dislocation rate, but the downside of it is a persistent limp for weeks. And so this is not a commonly used procedure, but historically it was more common, and people will still describe it. You may hear a lot about the direct anterior approach, and this was popularized by a trauma surgeon where you have to use a specialized table to expose the hip. There has been mixed results with this because you're attacking the hip from the front. There are various neurovascular structures there, so some patients, some physicians have reported nerve injury because of the plane that you have to go. They'll advertise anterior hip replacement as muscle sparing, you don't cut any muscle, but the literature also describes permanent injury to some of the nerves nearby, causing pain and numbness. This study and this study here, these both basically confirm what I was telling you before, that after 6 weeks or so, there's really no difference of any of these approaches. There is a group across the bay who takes big newspaper ads describing that they do the most anterior hip replacements in Northern California. What's interesting is a competing group, Stanford, somehow got their data and published it in one of the orthopedic national journals. And what they showed is that while this group is advertising doing the most anterior hip replacements, it took them 165 minutes on average to do a hip replacement. Remember, I told you it takes about 60, so it took them almost 3 times as long. Their blood loss was 2 times as much as a typical hip, and they had a 9% complication rate, nearly 1 out of 10. So you won't see that in the advertisements, you won't hear that, but what this is showing you is that that approach can be more difficult, can be fraught with complications, so you really have to do your research, not just believe the ads that you see. This JBJS is one of our most respected orthopedic journals, and these articles show that higher volume hospitals, higher volume surgeons typically will have better outcomes, and that makes sense. This is standard hip replacement. This is less invasive hip replacement. Both get you hopefully a good, long-lasting hip replacement. There's no problem with either. Both can work very well. The bottom line is you want a well-done hip replacement that will last you years and years. So my general recommendation is do research, talk to your surgeon, find out what they're doing. Higher volume typically means fewer complications, and then let your surgeon discuss the pros and cons of each with you. I'm going to quickly talk a little bit about bearing surfaces, because you may have heard about it on television, read about it in magazines, about some of the downsides of metal on metal bearings. So what you passed around was metal on plastic or ceramic on plastic. This was using a metal ball that would articulate on a metal liner. And the problem was that anything that moves against something else will wear, and so this would create metal ions actually in the bloodstream. And so this came out in the New York Times, where the metal on metal bearing, the idea was that it would wear less, meaning that it would be better for young people. But what happened is that these were failing at a much higher rate. So they had a recall, and New York Times, you can see it was typically younger people. So the exact people that you were trying to avoid revision surgery on were needing it much sooner because this metal on metal device was failing. This is a physician in Chicago who I also trained with before I came back here, who's really the nation's expert on metal issues with hip and knee replacement. And these were his comments when J&J or DePuy, a couple years ago, they had to recall 93,000 hip replacements because their metal on metal implants were failing. Ceramic on ceramic is another bearing. The idea is to reduce wear. But the problem with ceramic is, as you know from your ceramics in your house, they're very brittle. So when they fracture, they can shatter. And if they shatter, then they can obviously leave dust particles and other problems in the hip joint. In addition, a somewhat unique problem with ceramic hips is they can squeak. So this is, I don't know if you can hear that. That's someone's hip replacement squeaking on every move. And New York Times picked that up. This is somewhat unique to a ceramic on ceramic hip. So you can imagine that might get annoying after a while. He might not have pain, but he's also not going to sneak up on anybody. So it's important to know, with all these advancements in orthopedics, like anything else, we have to be aware that it may introduce new complications, new problems we've never heard of before. The conclusion is that traditional metal on plastic or ceramic on plastic works extremely well, Metal on metal, there are ions that can cause failure and problems. Most people are not doing metal on metal anymore. Ceramic can fracture, but there may be a role against plastic articulation. And again, these plastics are more and more durable, lasting decades. Quickly, I'm going to talk to you a little bit about some perioperative advances. So in addition to the hip replacement surgery, other things that we're constantly working on are how to improve pain control, how to minimize blood management, or how to minimize blood loss, with better blood management. One of those things is pain control. Typically, when people have pain, the idea was give them narcotics, more and more narcotics, but then you have downsides of that, right? There's nausea, constipation, sedation. You want to try to avoid those medications which have all the side effects. So we really try to stay away from narcotics if we can. Pain starts at the tissue level, goes to the spinal cord, and works up to the brain. There are various ways where we can intercept that pain and hopefully have fewer side effects. So we can use local anesthetics, meaning we can use numbing medicines at the site of surgery. We can do things like peripheral nerve blocks to block pain, like an epidural. We can use some narcotics, but we can also use anti-inflammatories or even things like IV Tylenol. So Tylenol, which we talked about, is over the counter. It can be used for pain. I've been using this lately in an IV form, and what happens in the IV form is it more rapidly gets into the bloodstream, more rapidly is effective at the brain level, reducing pain with really very few side effects. I also use things like Celebrex, which is a powerful anti-inflammatory, or Toradol, Ketorolac, which is an IV anti-inflammatory. All these things are very effective in reducing pain without those side effects of the narcotics. Lyrica is a nerve medicine, which I've also been using lately, which can help reduce pain after surgery. We have various blocks. Anesthesiologists can do epidurals and other things which can help reduce pain around the perioperative period. The other thing that I've been doing a lot of recently is using this new medication called Exparel, which is a local injection. So like the Marcaine or Novocaine your dentists use and makes your mouth numb for a few hours, this medication is actually the same thing. It just releases over a period of time. And so you can see in this graph what happens is this bupivacaine or Novocaine essentially is released over possibly 72, 96 hours. So I can inject it around the hip and it can stay there and it can give pain relief for multiple days without having to take any pill whatsoever. So this is something new, that's an advancement that seems to be working very well. In addition, I've been using things like tranexamic acid, which helps reduce bleeding. And so we typically don't have to use drains, for example. We don't have blood transfusions. We don't have people who have blood loss and are lightheaded or dizzy because we can minimize the blood loss with surgery. There are also things I can use in surgery like a cautery or a bipolar sealer device which stops bleeding at the surgical site. So all these things, in addition to this, which are topical thrombins or things that help in the clotting cascade, I can apply it superficially to the surgical wound and it will clot the bleeding there. And what happens is with less bleeding, there's less pain. With less pain, there's faster recovery. People walk sooner. All these things help speed recovery. In addition, I've been using some novel suture. Everyone's familiar with typical suture. You tie a knot. When you have to close a wound, when you do that, there's obviously many sutures, many knots, which is a lot of foreign material. This is actually a unique suture, which is barbs. They cut little nicks into it, and then what happens is it catches the tissue like a porcupine quill, if you will. So what that means is I don't have to tie any knots. It will engage the tissue. It can close. And so rather than using staples or other things you may have seen, I can close the skin like so you can barely see it and it heals very well, or in a hip like so. And lastly, another advancement, all these small things help improve perioperative recovery, is this dressing. And what this dressing is rather than having the caretaker or the husband wife at home change the dressing every day, peel tape on and off and have skin blisters or non-sterile technique, this is a unique dressing which is like a second skin. It applies to the area. It can stay on for 7 days. It's waterproof. It has some antibacterial properties to it, so it gives you reassurance that it's sterile, stays on for 7 days, and you can shower right away. So all these advancements, rather than having something like this, a typical dressing which drains and has to be changed, you put one dressing on for a week. All of these small things might not make a difference by themselves, but by combining all of them, again, it helps speed recovery so patients can get back to their life sooner. What does this mean? It means that we can even take joint replacement into the outpatient setting. So I'm currently in the process of opening our outpatient surgery program, where I'll be taking some knees and potentially some hips to the outpatient center, provide the joint replacement, and have people go home the same day. That's how quickly we've advanced with our recovery, and I expect that to be coming in the upcoming months. Unique to our program at Washington Hospital is our Institute for Joint Restoration, where we stress education. Every patient goes to a class which is taught by our therapists and nurses, so they and their caretakers know everything they need to know about before, during, and after surgery. They're also provided binders giving that same information, and they're exposed to the entire IJR personnel, which is a huge group of people. It's a huge concerted effort of obviously the surgeons, but our anesthesiologists who work with us, our OR nurses and techs, our nurses and therapists dedicated to what we do. And what that means is that they can provide the best care possible in our Center for Joint Replacement building. This is our office on the top floor. This is the nursing station and the hallways and the typical private room, so 30 private rooms. But because that building is its own freestanding building, the only people in there are healthy people wanting elective joint replacement. The nurses, therapists, their only job is to take care of joint replacement patients. So you're not on a hospital floor, you don't have a roommate, you're not on the floor with people who have had other surgical procedures or other illness. You are in a building dedicated only to helping healthy people recover from elective joint replacement. Because of the high volume we do, like I alluded to before, this allows us to present our clinical research on a national basis multiple times a year. Like I said, I just came back from Dallas presenting some of our work, looking at things like our results with cemented hip replacement or our bilateral knee replacement or using different sizes for different people, the gender knee, for example. But all of these studies we present to help shape the care of surgeons across the country. Fremont is right here. Our reach of patients is much larger than that. We often have people coming from out of state, Hawaii, Oregon, Texas. People come from all over to come to our program because hopefully we provide a good result and because of our reputation. And this is, PRC is just one of the groups that will look at orthopedics and the patient satisfaction. It's been the #1 orthopedic facility in the country for multiple years in a row. Health Grades is on the internet. You can look it up. It ranks all hospitals, UCSF, Stanford, and ours. 5 stars is their highest rating. We are the only entity in the Bay Area that receives their top rating for both hip and knee replacement. That's been for the past 12 years. And in 2012, we were the #1 joint replacement facility in California. Consumer Report came out with this last year, where they rated, again, all the hospitals in the country. And you can see here, the red dot is the best and white's the middle. You can see Stanford and UCSF are in the middle. We're at the red. And then they looked at, in California, all of the highest rated knee surgery hospitals, and we're one of maybe 10. And if you look for the highest rated in hip surgery, we're one of maybe 5, and we're probably one of only 2 or 3 that are top in both. So we try to live up to that reputation. We want to provide the best care possible. This is our website, and there's more information there. But thank you so much for your time and attention, and I'll be happy to answer any questions that you have. Thank you.